Welcome, everyone. It's a pleasure to have you joining us this Friday afternoon. Today is July 23rd, and it is our sincere privilege and pleasure to share with you part two of a two-part webinar on the National Pandemic Pulse results from work that we've been now doing for the better part of the COVID pandemic. It's my privilege to be introducing an outstanding team of researchers from across the Johns Hopkins Bloomberg School of Public Health who have been carrying out this nationally representative survey to understand some of the inequities that the COVID pandemic has exacerbated and revealed in greater detail in the US population. So it's been a privilege to do this work, supported by a grant from the Johnson & Johnson Foundation, and this is the third round of this series of surveys that began earlier in 2020. So with that, let me introduce some of the broad topical areas, and then we will go into specific presentations from each of our researchers who have been participating in and helping to lead this work. I'm Alan Labrique. Apologies for not introducing myself earlier. I'm a professor in the Department of International Health and the director of the Johns Hopkins Global Digital Health Initiative. So as we all know from the early days of this pandemic, the impact of COVID-19 has not been equally distributed in the US population. And as we have seen around the world, the segments of society that have borne the brunt of the population, the brunt of the impact of COVID are often those who have for many, many years, decades, if not longer, experienced social and economic inequities in this population. As we've seen in the very early days, this is data from March of 2021 by the COVID Tracking Project and the Boston University Center for Anti-Racist Research, that Black people and Native Americans have died at nearly 1.4 times the rate of white people in this country, approximated closely with Latino and other Native populations. Next slide. This has been also confirmed looking at electronic health record data. This is data from the Kaiser Family Foundation showing that the hospitalization rates and death rates have also mimicked the inequities that we just saw in terms of gross mortality. Again, much higher among Black, Hispanic, and somewhat in Asian population groups, but again, reflecting historical longstanding inequities that these populations have represented in terms of access to resources, access to healthcare, and engagement in essential work that puts them at increased risk. A recent article in the New York Times also looked at disparities in vaccine coverage. And as you can see here in the orange dots represent the proportion of populations in these particular states that are Black versus the proportion of individuals who have been vaccinated. And you can see here that according to different states, the disparity between the proportion of African Americans in that particular state and the proportion vaccinated continues to be a fairly large gap, especially in southern and southeastern parts of the country. Next slide. One of the most sobering statistics that recently has been dominating the news cycle is about the decline in life expectancy from 79 years in 2019 to about 77 years in 2020, according to the CDC's National Center for Health Statistics. This is a massive 1-year decline since World War II. And we saw that Hispanic and Black communities saw the biggest declines during this stark drop. This important loss of life expectancy, again, is another reflection of these inequities that exist within the US population, concentrated within African American and Hispanic segments of our communities. Next slide. So I think one of the impetus for us to enter into this very important type of research was really for us to shed light on these inequities and the disproportionate burden that is experienced by African Americans and Latino populations and other minorities within our national population, where the effects of systemic racism not only has immediate impacts on the risk of COVID infection and the short and long-term consequences of the pandemic, but the fact that these racial inequities and racism that we have in our society leads to increased rates of both disease and mortality that we should be working to prevent and circumvent in the near future. Next slide. So I just wanted to make very clear as we embark on this webinar that as we have done in every other webinar that we've presented in this series, all of which are available recorded online, and as fast as we can get them into the peer-reviewed literature, we are doing so. But our research aims to describe differences in perceptions of risk, social exposures, access to information, both distal and long-term consequences of the COVID-19 pandemic. And we are using race as a socio-political framework, and certainly not a biologic one, to examine underlying systemic racism and the consequent inequities that are presented by these social constructs. The same is true when we use ethnicity. So given the nature of the study and the fact that we are, despite our large sample size, still limited by the degree of nuance that we can capture, we've tried to address these in multivariate and complex analyses to the extent possible. Next slide. Next slide, please. Apologies, we have a distributed team around the globe, and so some delays are regrettably being experienced as we transfer slides. So with that, let me transfer the baton to my colleague, Dr. Dustin Gibson, who is going to present some of the methodologies, and we will then jump right into the meat of our findings. Thank you. Dr. Gibson.
Dr. Ulrich, do you want to take over from here? The slide finally advanced.
Oh, I'm sorry. Well, let me before we jump to the methodology, let me just point our audience to the website where all of our current findings and the findings from the last 2 rounds of this work are represented, covidinequities.org. You can find recordings of this and other webinars, publications both in medRxiv preprints as well as peer-reviewed literature that have come out from this work, as well as interactive dashboards that you can manipulate the data yourself as you want to explore this data. We're also happy to explore sharing the raw data with folks who are interested in doing their own analyses or merging this data with other analyses that they are conducting. And for that, please contact our team and we'll be happy to explore that with you further. We also have been releasing policy briefs that are targeted to different policy making audiences, both at the local, state, and national levels. And so those are also available at the covidinequities.org website. Next slide. And please I see a number of you have been introducing yourselves in the chat. Please do continue to do so, and we'll be thrilled to know where you're logging in from. So just to let you guys know, last Friday we did part one of this this two-part series. It's a lot of data that comes from these nearly 9,000 respondents that that have been collected during each of these rounds of the Pandemic Pulse survey. And so last Friday we focused on disparities in testing and outcomes, vaccine acceptance among pregnant women, the impact of COVID-19 on maternal and neonatal outcomes, and some trends in mental health as well as substance use. Today, we'll be focusing on vaccine resistance and hesitancy, led by Dr. Dustin Gibson. We'll be looking at masking intentions and sources of COVID information from Alex Zapp. From Dr. Wolfson, we'll hear some more exciting information about food insecurity and access to nutrition assistance. And from Monali Nakanti, we'll be hearing about schooling, resumption of education, student performance, and well-being. So if you missed last week's webinar, it will be available on our website, covidinequities.org. So do feel free to log in and listen to that recording. I will give you a short summary, next slide please, of the key findings of last Friday's webinar to entice you to go and watch that recording if you haven't had the ability to do so. And here it's broken up into really high-level takeaways. First, let me focus on the testing and test positivity. One of the things we've seen in this third round of this national survey is that although testing availability is widespread, we continue to see disparities persisting in COVID-19 outcomes. We've seen that Latinx respondents do still report higher test positivity than other counterparts within the US population. We've seen that across all groups, individuals reporting comorbidities, namely chronic health conditions, had worse outcomes across all groups measured by hospitalizations. Shifting focus to pregnant women, one of the things we saw in the December survey were that pregnant women were more willing to receive a vaccine. However, in the more recent round of this survey, that has not translated into a higher vaccine rate among pregnant women. However, pregnant women were more likely to have considered never receiving the vaccine and were overall less likely to be vaccinated. What is very sobering, and other researchers have shown this both clinically and at a population level, is that pregnant women were more likely to report testing positive and be hospitalized compared to matched non-pregnant controls of the same age and demographic group. This was true both in December and June of 2021. Pregnant women with positive COVID were more likely to experience delivery complications and adverse pregnancy outcomes, especially among African-American women, but it's possible that it was explained by chronic conditions that that seem to reduce the association between COVID positivity and adverse pregnancy outcomes. Finally, the excellent work done on reviewing alcohol, tobacco, and marijuana use found that a sharp uptick in the use of these substances associated with COVID-related psychological distress and job loss. So some sobering findings about the continued impacts of COVID-19, even though as a nation we continue to rush towards reopening and resumption of normalcy, we see long-lasting impacts that that we continue to struggle against, especially related to inequities and the effects of systemic racism on the sequelae of this pandemic. Next slide, please. And I think now I hand it over to you, Dr. Gibson.
Yep. Yep. I think this is, yes. Thank you. So, yeah, my name's Dustin Gibson, and as Dr. Labrik mentioned, our objective is to quickly capture the pulse of the nation through multiple cross-sectional surveys over time, where we typically are surveying respondents every 2 months. These surveys contain questions from existing COVID surveys, as well as those identified by team members that appeared to be lacking in the literature. Our final questionnaire for each round is reviewed by folks at the School of Public Health, as well as the School of Medicine. And our survey contains a core set of COVID-19 questions that we ask each round to see how they change over time, such as COVID testing and outcomes, as well as the ability and flexibility to add in new trending topics, for example, school reopenings in our last September survey and behaviors following vaccination in this survey. Of note, I would like to highlight that our large sample size, nearly 9,000 complete surveys, makes our work unique from others in that it allows us sufficient statistical power to examine health inequities in a range of subpopulations from race, age, gender, to political affiliation. We contracted Dynata, which is one of the largest first-party data platforms in the US, to deliver our survey. So what Dynata does is they send an email request to a targeted but random sample in order to create a nationally representative survey on gender, age, race, census division, and income. This survey was an online survey that programmed onto an enterprise version of SurveyMonkey, where participants were eligible if they were aged 18 and older and a US resident living in the 50 US states. The exciting results that we'll be sharing with you today come from our third survey round conducted late May through early June of this year, where we received almost 9,300 complete surveys. As I mentioned, this is our third round of data collection, with previous rounds occurring in September and December of last year. Our team is furiously working at putting together a questionnaire for an upcoming fourth round, and would love to hear from you in the audience on any areas that we think should explore or merit exploration. Our most recent survey included a set of demographic questions and 10 COVID related modules that are listed here. Alan went over the modules that were presented last week. Just wanted to highlight that the bolded modules are those that have been repeated over time. So hopefully in our next seminar in a few months, we'll be able to do some long-term longitudinal analyses. And lastly, I won't spend too much on this slide other than to point out that you can see our quota sampling approach produced similar estimates to those on gender, race, ethnicity, and age as compared to the census, with the census estimates in blue and our survey results in red. Here, the pie chart on the right just shows our representative distribution on household income, with about 20% of our sample reporting an income of less than 20,000 US dollars. And before moving on to the main show, I just wanted to emphasize that many of our analyses we will be sharing are preliminary and of the univariate nature, unless otherwise indicated. We thought it was more important to get these results out as soon as possible, in lieu of conducting more elaborate and sophisticated analyses. So with that, it's now my pleasure to introduce Dr. Dustin Gibson and his talk on vaccine resistance. All right, well, Dustin, thank you very much for that introduction. I will now be talking in the next few slides on vaccine resistance and hesitancy. So let's just jump right into it. So our pandemic pulse has been collecting opinions on COVID-19 vaccines since its launch in September 2020. In this figure here, we have self-reported COVID-19 vaccination status in the blue, compared to national estimates by CDC and others in the red. And so you can see that our sample has about a 10 to 15% higher proportion of fully vaccinated and partially vaccinated individuals than these other national estimates. If we look at the right here, we see that about 35% of our sample, again, this is a May to June sample, had not received a single COVID-19 vaccination. And so if we blow up this 35%, or about 3,100 individuals, we can see that about 11% wanted the vaccine but had access issues. Another 29% wanted the vaccine, it's been scheduled. And really the most sizable percentage is this 60% that indicate no, they don't want the vaccine at all. And throughout the rest of the talk, I'll just sort of be referring to them as the vaccine resistors. So again, here's the same pie chart from the last slide, but let's zoom it out to the entire population to see how prevalent this issue is. So when taking a population approach, we see that 1 in 5 of our respondents indicated that they will not receive a COVID-19 vaccine. As I mentioned, I will call these 1 in 5 the vaccine resistors, and I will spend some time trying to identify the socio-demographic characteristics between these resistors and the COVID-19 vaccine acceptors, understand the reasons why vaccination is being refused, and then lastly, to compare trusted sources of vaccine information between the two groups. In the next few slides, I'll show you cross-tabulations for not wanting the COVID-19 vaccine on the y-axis by a series of different socio-demographic groups. So here with this red bar indicating our sample's average, we can see that younger age groups are more likely to not want the COVID-19 vaccine. And on the right, females reporting about an 8% to 10% absolute increase in not wanting the vaccine as compared to males. Here we have the same slide up, but this time we are looking at self-reported household income and respondents' highest levels of educational attainment. So for both characteristics, we see an inverse relationship with lowest levels of income and household wealth having the highest levels of not wanting the vaccine, with about a 25% gap between those making less than $20,000 per year and those making greater than $150,000. And lastly, here's a similar slide, again, same setup, but this time looking at race on the left, race, ethnicity, and political affiliation on the right. And here we see that vaccine resistance is highest in the non-Hispanic Black subpopulation. And for the political party, we see that those identifying as a Republican have highest levels of vaccine resistance, and those identifying as a Democrat have the lowest levels. Sorry, there we go. So we took all of these independent variables from the previous few slides and placed them into a multivariable logistic regression model to examine the odds of not wanting a COVID-19 vaccination as compared to those receiving or wanting it. And so in this forest plot here, On the right, an odds ratio to the right of 1 and whose confidence intervals do not overlap with 1 suggests that the characteristic is associated with not wanting the vaccine or increasing vaccine resistance. So here in our adjusted model, if you remember all the previous slides, we can see that all of those bivariate analyses hold true in our adjusted models, with notably Republicans having 4 times higher odds for resisting COVID-19 vaccination as compared to Democrats, the reference group, and non-Hispanic Blacks having almost 2 times higher odds than non-Hispanic whites. So I think we can agree that these are sort of 2 separate subpopulations that may warrant further examination. We also, this was also included in the model. I just didn't have enough space, but we included the census division in our adjusted logistic regression. So here the reference is the Pacifics division, which includes California, Washington, Oregon, Hawaii, and Alaska. And we see that the West, South Central, and the South Atlantic divisions had higher levels of COVID vaccine resistance. I know many of us may not be up to date on our states by census division. So here on the right are those states with our percent resistor in this column, and then administrative data showing those that had received at least 1 dose. Please keep in mind our survey was representative to be for age, sex, race, and income for the census division, so that we have small sample sizes for states. But still, if we look at the South Atlantic, where there's a larger spread, here I've rank ordered them. In the resistance estimates, we can see that these estimates largely do map onto the 1 dose coverage. So lower, higher resistance, indicating lower vaccination coverage. So I just showed you our attempt to characterize the COVID-19 vaccine resistors. Now, for those who indicated resistance, we asked the respondents to provide reasons why. So here in the column on the left, I am showing results from our December round 2 survey, and next to it, our most recent estimates to see how these may have changed over time. So in short, you can see that the 3 main reasons for being unwilling to receive the vaccine stayed consistent: vaccine safety concerns, long-term health concerns, and then vaccine efficacy concerns. But there's really 2 other points that pop out. Is that first, we see a substantial decrease in those reporting that they would be willing to get the vaccine, but not be one of the first. Remember, COVID vaccines were first released in early December 2020, and very few people have been vaccinated by the time of that survey. And then second, we see a substantial proportion in the increase in those reporting that the vaccine is unnecessary, from 15% or so to 23%. Since we can't examine these reasons by vaccine acceptors and resistors, I thought I would look at the 2 socio-demographic characteristics that were most strongly associated with vaccine resistance. So race and ethnicity on this slide, and then the next slide will be political affiliation. So in short, again, the top 3 concerns were similar across non-Hispanic whites, Blacks, and Hispanics, with the non-Hispanic Blacks reporting slightly lower levels of concern for long-term health consequences. But really the largest relative difference here was the vaccine is unnecessary, where non-Hispanic whites and Hispanics to extent have 2 times higher reporting rates than non-Hispanic Blacks. So we next looked at these same reasons, but this time stratified by political party. Again, we see this the top three reasons are largely similar, with notable exceptions that Republicans are reporting higher levels of vaccine safety, about an 8% compared to Democrats, and then also long-term health concerns. But what I really find more alarming, however, is that nearly 1/3 of the Republicans who are resisting the vaccine, so these are just Republicans who have not been vaccinated, 1/3 of them indicate that the vaccine is unnecessary as compared to 13% of Democrats, which I think really just highlights some of the unfortunate politicization of this pandemic. We next asked all the respondents, which source do you trust the most for vaccine information? The previous slide, individuals could select, all that apply, but here it was just the single most trusted source. So data are presented here overall and by vaccine resistors and by the acceptors. And so that we can see that here that the vaccine resistors are much less likely to indicate that CDC or a state or local health department is their most trusted or go-to source. And that quite interestingly, family members are more trusted information than the CDC for these vaccine resistors. So my last two slides are on vaccine hesitancy. So for those who received a COVID-19 vaccine, we asked, and I quote, "Since the COVID-19 vaccines were authorized for emergency use in the US, did you ever seriously consider not getting a vaccine?" So we see for those that were fully vaccinated on the bottom, about 25% reported being hesitant or seriously not considering receiving the vaccine, as compared to more than half of those who are currently partially vaccinated. And this makes sense, as this round of survey was conducted at a time when the vaccine had been available for about 6 months. So it's likely that those who waited until just recently to get the vaccine had some hesitancy concerns, thus delaying their vaccination. But I also think it highlights that there is no such thing as a universal pro-vaccine crowd. Even among those who are fully vaccinated, nearly a quarter had serious considerations and reservations about receiving the vaccine. And for my last slide, for those who reported hesitancy but ultimately were vaccinated, we asked what factors influenced their decision to change their mind. So here we see a strong top three of doctor's physician recommending, followed by a public health agency, be it local, state, or national, and then followed by friends and family. So interestingly, if you recall from our previous slide, our December survey found that of those unwilling to get a COVID vaccine, 25% they would eventually get it, but not be one of the first. And that finding, moving forward, matches pretty well with this fourth reason here that says, as more people got vaccinated, I trusted the vaccine to be safe and effective. And then lastly, we looked at these reasons by political affiliation and found that for the majority, Democrats and Republicans were in alignment, with independents showing higher percentage for the wait and see approach and the time to do my own research. And just so that I can't be accused of uniquely singling out groups, I would like to point out that Democrats, compared to others, were more influenced by the celebrities and media personalities. So in short, and to wrap it up, although our COVID-19 estimates were slightly higher than others, still we found that 1 in 5 Americans reported not being willing to receive a COVID-19 vaccine, which was similar to a recent finding from a Marist poll. Our multivariable model found that high levels of vaccine resistance was found in the youngest, in females, low income and education, non-Hispanic Blacks, and Republican or Independent Party affiliation as compared to the respective counterparts. As a word of caution, these demographic characteristics are rather broad, and we do need to dig deeper into these subpopulations to understand how we can effectively communicate with these groups and develop a more nuanced messaging approach. Compared to our December survey, we did find a substantial increase in vaccine resistors who reported that the COVID-19 vaccine is unnecessary. In regards to the sources of information, we found that vaccine resistors placed higher trust in their family for vaccine information and less trust in public health institutions than their counterparts, the vaccine acceptors. And then lastly, although we didn't spend too much time on this topic, we found about a quarter of all of those who were vaccinated had at one point serious reservations to receive the COVID vaccine, and that there were numerous reasons that caused their conversion, be it from a physician's recommendation to Beyonce, to whomever. So with that, I'd now like to turn it over to Alex for his talk on masking.
Yeah, thank you very much. Good morning, good afternoon, good evening. I am Alex Johnsup, and I will now present you our results on restrictions and masking intentions. So next slide, please, if that is possible. I cannot control them. I'm sorry. Just give me 1 second, please. So as many of you might know, this topic has been So here we go. As many of you know, this topic has been heavily discussed both on a societal level as well as politically recently across the globe and in the US, with many states and many countries globally lifting restrictions in response to declining cases, but more recently against the backdrop of a resurgence in COVID-19 cases across the globe in association with the Delta variant. Some localities in the US, on the top left here, you can see an announcement from the LA County Health Department that indicated that they will recommend masking indoors again. And so this topic remains as important as ever. Our approach for assessing these questions can be seen on this slide, which highlights the methodology for our modules. So for restrictions, we had 2 questions. So one was more broadly about if restrictions were implemented or not. And then the second one was more trying to capture the feelings in response to the change in restrictions being lifted. And then with regards to masking, we had 3 questions. One of them was related, 2 of them are related to vaccinated participants, and then the other one was for unvaccinated participants. Our analyses are highlighted on the bottom. And the most important thing here to note is that these estimates represent weighted results. So we use survey and design weights to adjust them and make them more comparable to the US population on the national level. I will now start with presenting our results about restrictions. So this is just a background snapshot of the situation or the context at the time. So just to reiterate what Dustin has just mentioned, the survey was rolled out at the end of May, early June. And at that point in time, we can see that about 60% of people reported that they lived in a locality or a place where some restrictions were lifted. As additionally, there were almost 30% of people that reported that all restrictions had been lifted. So this is just a background snapshot to give you the context, and we have to acknowledge that these restrictions might have changed since then. if we now look at the feelings in response to lifted restrictions, so the reactions, we can see on the left here in this bar graph that over 50% of US Americans actually reported either being slightly or very anxious about restrictions being lifted. And then on the right, we have multivariable models. So these are models that simultaneously adjust for a variety of factors, including socio-demographic factors. So they represent independent estimates, and they're also adjusted for regional variation to account for geographic confounding. So in these multivariable models on the right, we can see that reactions in response to lifted restrictions are mostly driven by age, income, as well as political affiliation. So we can see younger age groups being less likely to report being anxious or very anxious. And the same goes for higher income groups compared to lower income groups, which in our survey was less than 20,000 per year. And then for political party, we saw strong variability with people that either reported being Republican or considered themselves independent or affiliated with another party being substantially less likely to report being anxious or very anxious as compared to people that lean towards the Democratic Party. We also did an analysis based on our mental health module, which was presented last week. And we looked into the association between restrictions being lifted and anxiety as well as depression as measured by the PHQ-4 questionnaire. See on the left, you can see that in places or people that come from places where all restrictions remained in place, we saw the highest proportion of people reporting feelings that were indicative of anxiety. Whereas in places where some restrictions were lifted, we observed the lowest level of feelings indicative of anxiety. And once we look into that in our multivariable models, the results slightly change. So the findings for places where all restrictions remain in place became non-significant, whereas the effect for places where some restrictions were lifted was significantly reduced in terms of the likelihood being significantly reduced of reporting feelings indicative of anxiety. We did a similar analysis that we are presenting here on depression or feelings indicative of depression. Once again, on the left, you can see that places where all restrictions remain in place, people from those places reported an increased proportion of feelings indicative of society. However, on the right side, we can see that once we adjusted for this in multivariable models, the results became statistically non-significant. Another analysis that we did based on the previous module that was just presented to you on vaccination status, we looked into the association between reactions to lifting restrictions and vaccination status. So to recap, we either had people that said, yes, I got the vaccine, no, but I'm waiting. So either they had difficulty accessing it or they had scheduled to get one but hadn't received it yet. And then on the right side of the left graphic here, you can see we also had quite a substantial amount of people that reported that they do not want the vaccine. And a striking finding here is that among those that say, no, I do not want the vaccine, we had a substantially increased proportion of over 60% that reported that they were glad about seeing restrictions being lifted. And this also remains statistically significant in our modeling results on the right, where the adjusted odds ratios are significantly decreased, meaning that people that do not want a vaccine have a significantly decreased likelihood of being anxious or very anxious about restrictions being lifted. However, we have to acknowledge that we cannot assess causality with our analysis, so there might be some issue of reverse causality, so we do not know what came first, if people were happy or glad about restrictions being lifted and then decided not to get vaccinated, or vice versa, that they did not get vaccinated and then they were also happy about restrictions being lifted. So in summary, we found that over half of US Americans reported either being slightly or very anxious about local COVID-19 restrictions. And this was particularly less significantly, this decreased significantly among younger individuals, higher income groups, as well as Republicans or people that reported leaning towards the Republican Party. And then lifting some, but not all COVID-19 restrictions was found to be associated with a decreased level of reporting feelings indicative of anxiety. And as I just showed you, people that said that they refused to get vaccinated were significantly less likely to be anxious about restrictions being lifted. So we'll now transition to our results on masking intentions. We separated these by people being vaccinated and people not being vaccinated. So this is our findings for people that indicated being vaccinated. On the left, you can see that actually more than 1/3 of those that received the vaccine indicated that they will continue to, or that they intend to continue masking both indoors and outdoors. And then once we look into the multivariable models on the right, we can see that race and ethnicity, as well as political affiliation, had the strongest influence on masking intentions among the vaccinated, with non-Hispanic, Black or African Americans, as well as Latinx and Hispanic populations, as well as all other races, which captures a broad array of different ethnicities and races. All these groups had significantly increased likelihoods of reporting that they will continue to wear masks as compared to white or Caucasian US Americans. For political party, we can see that those that tend to lean towards Republican Party, consider themselves independent or affiliated with other parties, were significantly less likely to continue mask wearing. Among the unvaccinated, we also looked into the reasons of why people chose to continue mask wearing after they got vaccinated. So this is vaccinated only. And the top two reasons you can see here is that people either intend to protect themselves and people around them, as well as protecting unvaccinated individuals, so people that have increased vulnerability. And a note of caution here is that you can see on the right of this graph, the proportion of people reporting concerns about variants is fairly low, but given the temporal context, this was at the end of May. So at that point, the Delta variant, which is now dominant, wasn't really established in the US, so it wasn't widespread. I will now continue to present the results among unvaccinated individuals. So you can see a similar but slightly different association here on the left side, a U-shaped association with high proportions both in the polar ends of people that say no masks are totally unnecessary. And then on the right end, you can see that there's over 1/3 of unvaccinated people that reported that they intend to continue masking indoors and outdoors. And once again, we saw that race and ethnicity, as well as political affiliation, had the strongest influence on masking intentions among the unvaccinated, as we also observed for vaccinated. So on the right here, you can see that both non-Hispanic, Black or African Americans, as well as Latinx and Hispanic populations had significantly increased odds or significantly increased likelihood of intending to continue to wear masks, both indoors or outdoors, whereas Republicans compared to Democrats, which can be seen on the bottom left, were significantly less likely to intend to mask. In addition to that, we also did an analysis investigating the association between local restrictions being lifted or being still implemented and masking intentions among both vaccinated and unvaccinated. And we saw that local guidance matters. So local restrictions influence masking intentions after the vaccination. So on the left in the descriptors results, you can see that in the places where restrictions remain in place, we had a significantly increased proportion of people that reported that they will continue to wear masks both indoors and outdoors. However, the slightly changed in our multivariable models on the right on the bottom and the orange square or gold square, you can see that the effect for places or people from places where all restrictions remain in place was statistically non-significant, as the error bar, the confidence intervals, crosses the 1, which is the null value in this case. Whereas people from places where some restrictions, but not all, were lifted, reported a significantly increased likelihood of continuing to wear masks. And we also saw very similar results among the unvaccinated. So once again, places where all restrictions remained in place had the highest proportion of people intending to continue to wear masks both indoors and outdoors. And this effect was also statistically significant in our multivariable models. And then finally, we did an ad hoc, very explorative analysis based on the current resurgence in the pandemic in the US and across the globe, against the backdrop of increasing circulation or spread of the COVID-19 Delta variant. So on the left here, you can see data from the Coronavirus Research Center, so our colleagues there, highlighting the hotspots of current resurges in the US, which are concentrated in the South in states such as Louisiana, Oklahoma, Mississippi, and Arkansas, as well as Western or mountain area states including Nevada and Arizona. On the right, that is CDC data about the share or the proportion of sequenced samples that are sequenced or positive for the Delta variant. So B16172 is the Delta variant in this case. And you can see that the Delta variant is now dominant in the US, and specifically in the Midwest, the South, and the Western regions, we have increased proportion of the Delta variant among all samples being sequenced. So based on that, we looked into masking intentions by regional variation. And I have to highlight that these results or these analyses are very exploratory, and we cannot infer causality because there's a time lag. We did this at the end of May, early June, and the current resurgence is occurring in middle July to end July. And then we also, some of these numbers underlie small sample sizes. However, we can see that those areas and states where we are now seeing resurges had back then had slightly decreased in proportions of intending to continue mask wearing, and this also varied geographically. So you can see on the top bottom right that in states such as Mississippi, it was significantly decreased. And we saw similar results, but more dramatic results among the unvaccinated. So first of all, to highlight here on the right, the overall average of people that intend to wear masks or continue to wear masks was only 59%. And then the states or the regions where we are now seeing re-increases in COVID cases were below that, even though there was some heterogeneity or some variability. So for example, Louisiana had higher proportions, but on average, the states where now people are getting more infected back then had a higher proportion, a lower proportion of reporting that they will continue to wear masks. So even though we cannot infer causality, there are two major conclusions to be drawn from this. The first one is certainly that vaccinations continue to be the most important driver in combating resurgences in the pandemic. But then beyond that, even given our limitations, we could see that we can link data on health behavior or preventive behavior to COVID outcomes in our survey. So in summary, we can see that the majority of US Americans intends to continue wearing a mask, with actually more than a third of the population intending to continue mask wearing indoors and outdoors. However, this was substantially decreased among unvaccinated people. And the drivers that apparently make people wear a mask or continue to wear a mask were mostly protecting vulnerable people as well as oneself and the people around oneself. Further, race and ethnicity and political affiliation of individuals showed the strongest association with masking intentions, and we found that local public health guidance does matter. So people living in settings that maintain some level of restrictions are more likely to report wearing a mask in public. And with that, I would like to thank you and pass on to Dr. Julia Wilson to present on food insecurity.
Thanks very much, Alex. Let me turn on my screen and see if I can advance the slides. Let's see. Okay, great. So it's really my pleasure to join you all and to present these results about food security status among Americans in June 2021. Today, I'm going to present some preliminary results about food security status in June as compared to when we measured it previously in the previous wave in December of 2020. I'll also present some results on food security status distributions by age, gender, race, education, and income, and then also present some data about who is able to access free meals and groceries in the last 30 days, and access to social safety net benefits like SNAP or food stamps and WIC in the last 30 days based on food security status. This is a repeat module from December 2020, and these are the same questions we asked then. These are also weighted estimates that I'll be presenting. I just want to say a quick word about food security. So we were measuring food security status with the USDA, U.S. Household Food Security short form. This is a 6-question form that measures food security status in the past 30 days. Food security is really, or food insecurity rather, is defined as the limited or uncertain availability of nutritionally adequate and safe foods, or a limited or uncertain ability to acquire acceptable foods in socially acceptable ways. So it is distinct from hunger or malnutrition, but it's really around this uncertain access to enough and nutritious food to eat. The 6 questions that are in this short form module are on the right-hand side of the screen. And so as you can see, where participants or respondents are asked about, not having enough food to last and not having money to get more, not being able to afford to eat balanced meals, having to cut the size of the meals that they're eating less than they should because there wasn't enough money for food, or ever being hungry. These 6 questions are then scored on a scale from 1 to 6, and then we categorize them into 3 different levels of food security status. So food secure in the green, which will be green throughout the presentation, is a score of 0 or 1 on this 6-point scale, or 7.0 to 6 scale. And being food secure indicates that you do have consistent access to adequate and nutritious food. And that's about, almost 70% of our sample, 69%. Then there's low food security status, which is 14.7% of our sample, which indicates that you're worried about not having enough to eat. You may be reducing the quality or variety of your diet, but you're not reducing necessarily the quantity of the food that you are eating. And then very low food security status in red, which is about 16% of our sample, is a score of 5 or 6 on that scale, and indicates that not only are you worrying about having enough food to eat, but you are also reducing the amount of food that you are eating because your household lacks money for food. And so we combine this low and very low food security status into being the category of being food insecure as opposed to being food secure. And we find that 31% of Americans are experiencing food insecurity in June of 2021. And that is compared to 33% that we find in December of 2020. So here I'm comparing December in our survey in the gray bars compared to the blue bars, which is their June. And you can see that this is a remarkably consistent level of food insecurity. We see slightly more people in this food secure category in the blue, which is really driven by this reduction in the low food security status, but almost exactly the same number of people, or the same percent of our sample is experiencing very low food security status in June as compared to December. I will also note that as we move forward in some of the demographic comparisons, those also remained strikingly similar in June versus December. So I'll only be presenting the June results, but those trends that I'll be showing were very similar to what we saw in December as well. So for a little bit of context for this, 31% of Americans experiencing food insecurity and in the context of this pandemic, historically, this is an extremely high level of food security for the American, or food insecurity for the American population. This is going back to 2001 using this food insecurity measure. And this dark blue bar is food insecurity, that low and very low level combined. And you can see that even at the height of the Great Recession in 2009, 2010, food insecurity really reached just about 15%. And now in the context of COVID, we're seeing, almost a third, or about a third of Americans experiencing food insecurity. So it's really strikingly high. We also have seen historically pretty consistent patterns of race-based disparities in food security status. So here you can see the same time frame, and in the blue and orange bars that are substantially higher than the others represent Black and Hispanic Americans, and you can see they, historically have much higher levels of food insecurity than the overall population and by their white peers. So getting into our data now, so this is now from this current survey wave, and again, these are weighted analyses. We see in the red bars, those who are experiencing very low food security status, in the orange bars, low food security, and then the food secure population in green, with the dotted vertical line representing that 31% population mean. So you can see that males are slightly more likely to be experiencing food insecurity than females. And then looking by race, we see a pattern that is pretty consistent with the historical pattern and pretty consistent with what we saw in December as well, that we see this disparity where non-Hispanic, Black, and Latinx populations have higher proportion who are experiencing food insecurity, that low and very low bars combined compared to whites and compared to Americans overall. 28% of whites are food insecure, whereas 1 in 3 non-Hispanic Blacks and more than 4 in 10 Latinx populations are experiencing food insecurity. When we look by age, we see that the levels of higher food insecurity are really concentrated in the younger populations. We see a very clear age trend with those who are 65 and above experiencing by far the lowest levels of food insecurity, but really in this 18 to 44 age categories, these first 3 bars are seeing the highest levels of food insecurity. When we look across education levels by the highest degree attained by the respondent, we see that less educated Americans are more likely to be experiencing food insecurity, although it's interesting to see that those with some college are also above the population mean and nearly at the same level as those with less than a high school degree, or a high school degree or less, rather. And then again, we see a clear income gradient as well, with lower income households experiencing greater food insecurity, which one would expect and is consistent with what we saw in December and with historical patterns as well. So turning to access to free groceries or free meals, we see that about 1 in 5, or 19% of Americans did have access to free groceries or a meal. We asked, in the last 30 days, did you or anyone in your household get free groceries or a meal? And we see that with this 19% is most concentrated in those with very low food security status. Over 50% of people with very low food status received a free groceries or a free meal, with about 1 in 3 of people with low food security status. So, those free groceries and free meals are reaching people who are food insecure, although there's still a large unmet need. Where are these free meals or groceries coming from? So looking among that 19% who did receive any free meals, we can see that the most common sources of free meals are coming from food banks and from schools. So keeping in mind, this survey was fielded at the end of May and early June when schools were still in session for the most part. This is not surprising, and this is also, this overall pattern being presented here is consistent with what we saw in December as well. Go. Okay, turning to benefits. So about 1 in 5 Americans receive SNAP benefits in the last 30 days. SNAP benefits, or Supplemental Nutrition Assistance Program, also known as food stamps, provides people money for food who meet a certain income threshold, and is the nation's largest nutrition assistance program. It expanded rapidly in the face of COVID-19 related needs. And in our sample, as I said, about 20% of Americans, or 1 in 5, did receive SNAP benefits in the last 30 days in June of 2021. WIC is another nutrition assistance program that provides money for certain foods for women who are pregnant or lactating, and children from 0 to 5 years old. So it's a much smaller program with a limited base. And in our sample, about 8% of respondents received WIC benefits. TANF and Social Security insurance are other social safety net programs that are fairly large, and then you can see a smaller percentage of our sample received those benefits as well. Notably, about 69% of our sample received none of these benefits at all in the last 30 days. That is down a little bit from what we saw in December. At the time, 72% of Americans received no benefits at all. And our SNAP benefit level was very consistent. In December, 18% of Americans received SNAP benefits. So SNAP receipt actually ticked up a little bit in June as compared to December. Oh, now I'm highlighting those. So who are SNAP and WIC benefits reaching? So looking at among people who receive SNAP benefits, they are mostly going to people who are experiencing very low and low food insecurity. Same for WIC, which is promising to see that those programs are reaching, for the most part, people who really need them. But more than 1/3 in the low food security group, 4 in 10 Americans are not receiving any benefits at all. And more than 1/3 of those with very low food security status are not receiving any benefits. So still a big unmet need in the context of this pandemic. So just to wrap up here, food insecurity is still historically high and is associated with stark disparities across a number of demographic groups. This is notable given the place we are in at the pandemic. In June, with the economic recovery and the American Rescue Plan and policies that have been put in place to support families and individuals and businesses, we might have expected to see some of these numbers tick down a little bit more than we did. Instead, we're seeing remarkably consistent levels of food insecurity and the associated disparities in June 2021 as compared to the end of 2020. The COVID-19 pandemic has exacerbated existing disparities that already were in place surrounding food insecurity, and our survey and numerous others have documented really extraordinary levels of food insecurity related to the pandemic. Black and Hispanic Americans have much higher rates of food insecurity compared to white Americans, and this need does not seem to be diminishing. And younger and lower income Americans are also more likely to be food insecure. So I think with that, I will now turn it over to Manali to go over schooling in a pandemic.
Thank you, Dr. Wolfson. Hi, everyone. I'm Manali Naganti, and I'm about to share a few of our findings around students experiencing with school and performance, as well as well-being. Lena, would you mind going to the next slide? Thank you. It's been a tumultuous year for students, as for all of us, but starting with the abrupt shift to virtual school last March and continuing into fall and spring of this academic year, it's been crazy. So as these recent headlines demonstrate, educators and parents around the country are now dealing with the prospect of returning to in-person school. A couple weeks ago, CDC released new guidelines in support of a full return to in-person instruction for K-12 students. And still, with the Delta variant surging across the country, unclear masking guidelines for schools, and most school-age children still not vaccinated, going back to school brings many unanswered questions. And one of the looming questions is the risk worth the benefit? And we hope to understand the second half of that equation a little better in this analysis. Next, please. As the slide comes up, I'll start talking about what we're about to cover. We'll briefly cover what instructional formats schools are offering in spring and how they vary by school type, grade level, and geography. We'll then take a look at what formats parents chose for their children and what factors drove those decisions. And finally, we'll examine whether the instructional format makes a difference for academic and psychosocial outcomes. Next. We were fortunate to have a large sample of respondents to explore these questions. All the respondents in our survey were asked if they had a child under 18 years old, and if they responded in the affirmative, they were given the opportunity to further detail schooling experiences for up to 3 children. In the final data set for this analysis, we ended up with 3,318 children in kindergarten through 12th, and across 2,143 parents. Nearly 2/3 of children attended public schools and another quarter attended private, and 3% were enrolled in charter schools. You'll see here that 8% of children in the study were homeschooled. As has been reported elsewhere, homeschooling rates have really jumped during the pandemic, and that number is substantially higher than the pre-pandemic level of 3.3%. There's also good representation in this data across the school levels, with the largest number of children in elementary, followed by high schoolers, and then middle schoolers. Next. White parents accounted for more than half the children in the survey, with Latinx parents claiming another quarter of the total. 11% of children had a Black parent, and 8% belonged to other racial categories. You have to keep in mind that we don't have demographic information on the children. The demographic information we do have is on the respondent to the survey, who is the adult reporting on their child. The parents represented a diversity of educational and socioeconomic backgrounds. And on the far right, you'll see sort of the political affiliation breakdown among parents, with 45% being Democrats and Republicans and Independents making up about a quarter of the population each. Next. Before we examine schooling preferences, we had to understand what choices were available to parents. And are others seeing their slides forward, or are we still on parental demographics? One more, please. Thank you. So among those who were not homeschooling, 84% of children had in-person instruction actually available to them in some form or the other. And there were no differences in sort of the availability of in-person instruction by either school level or type of school. Or by school level, but charter schools were less likely to offer in-person instruction than public or private schools. Next. We also looked at geographical differences, and the map will populate shortly, hopefully. And it'll show you that respondents in the central regions of the country were more likely to have in-person instruction available. However, across the board, in-person instruction was sort of widely available. It ranged from a low of 79% in the Pacific region, that includes California, Nevada, Washington, Alaska, and Hawaii, to a high of 89% in the West North Central region, which includes North Dakota, South Dakota, Kansas, Nebraska, Minnesota, Iowa, and Missouri. Next. Given the wide availability of in-person instruction, we were interested in understanding what choices parents were making for their children and what factors were driving those choices. One more, thank you. So when in-person school was available, more than half of all K through 12 students actually attended full-time in-person instruction. The choice of instruction format differed by both the type of school and the level of school. Students enrolled in public school were most likely to attend in-person instruction, followed by private school students. Charter school students were least likely to choose in-person instruction. And there were minimal differences in choice of instruction format between elementary and middle school age kids, but high schoolers were less likely to attend in person and more likely to receive instruction in a hybrid format compared to the lower grades. Next. We also looked at demographic differences, one more, by choice of instructional format. One more. And differentials in instructional format were most prominent by race, ethnicity, and political affiliation. So white and Republican respondents were more likely to choose in-person instruction than other subgroups. Next. Next, yeah, thank you. So these results are borne out in the multivariate analysis. Here you see a plot of our multivariate logistic regression. The covariates are on the y-axis, and you've seen a bunch of these, so I won't explain the plot to you. But after controlling for school characteristics and parental socio-demographic variables, race and political affiliation remain strongly associated with choosing in-person instruction. Just click a couple more through here. Just go ahead and let the boxes populate while I talk. Black respondents had less than half the odds of choosing fully in-person instruction compared to whites, and Latinx respondents were similarly less likely to choose in-person with an odds ratio of 0.62 compared to whites. Political affiliation, which is what you see at the bottom box over there, was associated, being a Republican was associated with more than 1.5 times the odds of choosing in-person instruction compared to Democrats. And in the top two boxes, you see that school level characteristics were also predictive of choosing, parents choosing in-person instruction for their children, kids. Let's just skip through that and go to the next one. Can you just go to the schooling outcomes one? Okay. Having identified some of the key factors associated with choosing in-person schooling, we wanted to explore how choice of instructional format related to academic and psychosocial outcomes. So we included 4 different items for psychosocial and academic outcomes, 2 for academic and 2 for psychosocial, and they're listed here. Basically, each item asked from a scale of 0 to 10 for parents to rate how they felt their child was doing, where 0 meant really struggling to 10 meaning not so great. That's fine, no worry. And we just dichotomize the results for our analyses to struggling versus not. So I'm going to talk about the academic outcomes first, and then I'll move on to the psychosocial ones. And I'm going to, I think, in the interest of time, I'm going to skip over sort of the bivariate associations and go straight to the multivariate model. Thank you. So after controlling for a range of socio-demographic outcomes, one of the things that remained most predictive of poor academic performance or academic performance and school engagement was actually the format of instruction. And in-person attendance was protective for both against poor academic performance as well as poor school engagement. Household income was the other sort of key variable that emerged as being significantly predictive of academic performance and engagement, where no surprise to anyone, higher income levels were protective against poor academic outcomes. Next, go ahead and go into we're going to talk about the psychosocial outcomes. Let's go straight to the multivariate models on these as well. Thank you. And so what you see here are multivariate models that predict either poor social adjustment or poor emotional well-being. They include a range of the socio-demographic variables we included previously, also instructional format, and also given the things that Dr. Wolfson pointed out in her presentation about school being a source of a primary source of food for food insecure families, and relationships between food insecurity and sort of cognitive outcomes and things like that. We included food insecurity as one of the covariates, and with good measure. So in this model, you see again that in-person instruction had folks who were receiving in-person instruction had lower odds of having poor social adjustment or poor emotional well-being, and being food secure was protective against poor social adjustment or well-being, whereas those who lived in very low food secure households or low food secure outcomes had nearly 1.5 times the odds for poor psychosocial outcomes compared to others. One surprising finding from this analysis was were the boxes in the center, that children of Black respondents reported significantly lower rates of adverse psychosocial outcomes than children of white respondents. Next, please. So, to summarize, as of June 2021, most schools were offering the option for in-person instruction, and majority of parents were selecting this option. Key predictors of in-person school attendance included attending a public school, having a white parent, or having a Republican parent. In-person attendance was associated with better outcomes across the board for academic performance, as well as psychosocial well-being. Food insecurity also emerged as an important predictor for poor psychosocial outcomes, but it wasn't significant for academic performance or school engagement. And finally, that finding that non-Hispanic Black respondents were less likely to report poor academic or well-being outcomes than their white counterparts. This is a surprising finding given the current understanding of inequities and the additional burdens placed upon Black and other people of color during the pandemic and beyond. And it may just be reflective of hesitation on the part of Black respondents to report hardships, but nevertheless, it requires further investigation. That concludes my presentation on schooling experiences and outcomes during COVID-19. Thank you for your time, and I will pass it back to my colleague, Alex, who will discuss findings on trust in science and sources of COVID-19 information.
Thanks, Manali. Before we begin with Alex's presentation, I just want to be cognizant that we are a few minutes before the 30 minutes into 1:30 that we said we would end at. If folks can stay with us a little longer, we're happy to have you. However, we are recording this session, so if you do have to drop off, feel free to visit covidinequities.org and listen to this last and exciting presentation about trust in science and sources of information about COVID-19 during the US pandemic from round 3 of the National Pandemic Pulse. So let me hand it over to Alex to take us through this last module. Thank you so much, Manali.
Yeah, thank you very much. I will now present a brief overview of our results for trust in science and sources and information about COVID-19. So these two topics have been following us pretty much since the beginning of the pandemic, and especially recently, they've been really prevalent in the media. So the US Surgeon General, Vivek Murthy, recently released a report or guidance on confronting health misinformation, and this has been heavily picked up in the media, especially in the relationship between misinformation and social media. So this is the methodology for a module. The most important thing on this slide is that the statements we used to assess trust in science and trust in information were slightly different. So for trust in science, we used, I trust scientists and scientific information to do what is right for my family and me. Whereas for trust in information from different sources, we used, I trust the following institutions or individuals to provide accurate information with regards to COVID. And both due to the relevance of these two sources of information and trust, as well as in the interest of time, I will just focus on trust in science and trust in social media for the rest of the presentation. So this is a brief recap of our findings from a second round, so round 2 in December 2020. On the right side here, you can see that the levels of trust in science were fairly high, with 3 out of 4 US Americans reporting that they either strongly agree or agree that they do trust scientists and scientific institutions, while social media on the left here was actually the least trusted source, which only a small proportion indicating that they would trust information from social media. So these are our results from the current third round. On the left, you see the descriptive results for trust in science, and you can see that over 70% of US Americans report that they do trust scientists and scientific information. And once we adjusted in our multivariable models on the right, we can see that education, specifically graduate education, as well as income in the form of higher income groups and political affiliation have the strongest effect on trust in science. And with regards to race and ethnicity on the top here, we can see that non-Hispanic, Black, or African Americans were significantly less likely to report that they trust scientists and scientific institutions in these multivariable adjusted models. For social media, we saw an inverse effect, and by inverse, I mean that the levels of trust and information from social media were substantially lower, with the majority, so over 60%, reporting that they either disagree or strongly disagree that they trust information from social media. And in our multivariable models on the right here, we can see that the main drivers or influential factors were age, specifically older age, then having lost your job or at least half of your income, as well as political affiliation. So for having lost your job or at least half of your income, you saw a particularly strong effect with a more than 2 times increased likelihood of reporting to trust information from social media. Whereas for race and ethnicity, we saw that there is quite some variability, and both non-Hispanic, Black, or African Americans, as well as Latinx and Hispanic populations, reported being substantially more likely to trust information from social media. So in brief, the summary for this is that trust in scientists and scientific institutions continues to be high among the US population, whereas trust in information from social media remains low. Thereby, trust in science is increased among people with high educational attainment, people from higher income groups, as well as people that tend to lean towards the Democratic Party, whereas trust in information from social media is increased among non-Hispanic, Black, or African Americans, as well as Hispanic or Latinx populations, and specifically people who report that they lost their job or at least half of their income were significantly more likely to report trust in social media. And with that, I'll conclude and pass on to Professor Labrik for the summary of the presentation.
Thank you so much, Alex, and thanks to our audience for joining today and sticking with us through these multiple modules that caps our two-part webinar. Again, for those of you who joined late or are joining us in the last few minutes, please do know that you could watch the entire recorded seminar at covidinequities.org. I think there's a lot that we're learning as part of these multiple time points spaced several months apart, going back to early 2020. And we're now in the third round of the Pandemic Pulse, the National Pandemic Pulse, which was conducted in May, June of 2021, with further rounds planned in the coming months as we experience a resurgence across some parts of this country, largely driven by the Delta variant, as Alex pointed out a few moments ago. I think we've seen that vaccine hesitancy continues to be problematic in the US as we strive to meet the federal targets that have been set by this current administration. We've seen that ethnicity, race, and political affiliation continue to be challenges for vaccine hesitancy or vaccine refusal. We see that lack of trust in federal and state health departments continue to be a major driver for vaccine resistance. And as we know, vaccines against COVID-19 are highly efficacious, safe, and do protect individuals against this deadly infection. And so we hope that these findings will help drive both policy and programs that improve vaccination rates. Anxiety continues to be high across the US despite improvements in the overall numbers of cases and mortality. And we see that anxiety is not homogeneous across the population, but does vary greatly by income level and age, as well as political affiliation. This may speak to echo chambers of news and information that drive some of these sources of information that individuals have, as well as perceptions around the state of the pandemic and risk factors surrounding COVID-19 risk of infection. One of the important findings, I think, from this set of presentations was around food insecurity that Dr. Wolfson pointed out is historically at an all-time high and is strongly associated with the stark disparities we see linked to institutional racism and inequities in the US population. I think despite the fact that we've seen improvements in COVID-19 infections and deaths, the rates of food insecurity have not dropped as dramatically, given the 6-month interval between the last two surveys. So comparing the results in June and December, June of 2021 and December of 2020, we see that that rates of food insecurity and dependence on free food continues to be extremely high. And Black and Hispanic Americans seem to be suffering much more severely from food insecurity than their white counterparts. I think we've seen the challenges and the unnecessary politicization associated with return to education, with the differentials in willingness to send their kids to school along racial and economic lines. We've also seen trust in science, which should not be political, continuing to be politically divisive issue, and a challenge that that does reflect this too fronted challenge that we're facing during this pandemic, one against a virus and one against both scientific illiteracy and misinformation. So I think we are not yet out of the woods. We have miles to go before we rest. And as the country reopens and we resume some aspects of normalcy, there remains quite a bit of work to be done, both to reduce inequities in our society, but also to continue to measure and mitigate the impacts of this pandemic along racial, ethnic, and socioeconomic lines. So with that, I want to give a warm thanks to all of our presenters who took the time to delve into this data and unravel some of the fascinating associations and patterns that the data does speak to, and also to the many folks who have joined us from across the globe to hear the results of this round 3 of the National Pandemic Pulse. Thank you all very much. And again, it's our pleasure and privilege to share this, this with you today. Stay tuned for round 4 coming in the coming few months of 2021. So with that, thank you everyone, and have a good evening, good afternoon, or good morning, depending on where you are in the world.